Thank you very much for the organizing team. I'm Dr. Christy for having me here. For me, yes, it's special because I'm back at my alma mater after quite some time. And moving on straight to the topic, after these energizing talks on the different variety of surgeries there for available for keratoconus, and you improve the patient's vision and strengthen the cornea from around 2 by 60, 3 by 60 to up to 6 by 36 or 6 by 24. This is going to be the missing link wherein you make your patient more happy by giving them 6'6" or 6'9". So keratoconus is a disease that produces irregular astigmatism, myopia from the anterior corneal displacement and the corneal scarring. So when giving a contact lens option, it is actually counterproductive. When the patient has a good unaided vision in one eye, then we don't go for it. And we leave the patient if the patient is also having a good spectacle vision, corrected vision. And it is, when indicated, you need to have a good, motivated and enthusiastic patient to carry them forward along with you for the contact lens journey. And the patient should definitely have a significant visual gain after your basic contact lens trials. The decision tree, yes, is topography based fitting, where I move on with starting from the basic variety of lenses and then going forward to the different variety of the scleral lenses. So the cornea is usually prolate, it is oblate in post myopic corrected LASIK, and in keratoconus it's usually having a hyperprolate shaped. The choosing of the contact lens or treating the keratoconus is in a step ladder pattern. Basically, I have the spectacle corrected astigmatism for very early stable keratoconus patients, and when the astigmatism is more higher, then I go on for a contact lenses. And even when it is a mild variety, yes, soft choric contact lens is the variety of choice. And then when it moves to a moderate disease, we go for rigid gas permeable lenses. And then if the patient doesn't have good improvement with the RGPs, or the RGP is not able to be fit, then yes, we can go for the more specialty variety of contact lenses. Having the different piggyback contact lenses is one option. The hybrid contact lens, wherein it is a single lens fabricated with two different materials of both the RGP in the center and the soft peripheral skirt. Then if the next level is the corneoscleral lenses and the scleral toric lenses also. When you decide to go for the contact lens for the patient, the aim of our fitting should be to give the best provided vision possible for the patient and to minimize the interference with the corneal physiology. We should have an optimized lens comfort, and materials of high oxygen permeability should be chosen to avoid any hypoxia related changes. The pre-fitting evaluation, yes, it includes a history, a baseline uncorrected visual acuity, the refraction, the best corrected visual acuity, and the clinical examination of slit lamp, intraocular pressures, the fundus examination, tachymetry, keratometry, the horizontal visible iris diameter, and the corneal topography and location of the cone should be looked into. Moving on to the RGP lenses, I usually fit it starting with the true K value. So true K is the K value of the flatter side in the 5 mm zone of the central cornea, and it represents the actual keratometric reading. So when we start from there, it reduces the chair time and increases the lens comfort to the patient. The contact lens parameters, very important for fitting of any contact lens, is the diameter of the lens, the base curve, and the power. So in the trial fit, after choosing the basic RGP lens, we give an adaptation period of about 30 minutes for the lens insertion, and then check on the static fit and the dynamic fit also. Static fit by instilling fluorescent in the eye and examining it under the cobalt blue filter. In dynamic fit, the lens is centered in the cornea and adequate close blink is checked. Stability in the different places and the should be comfortable during all these movements, which is very important. The different fitting philosophies available are of 3 different types. Previously used were the apical clearance method, the apical bearing method, but now the most commonly used is the 3-point touch, being the most widely accepted one. A few glimpses of all these things. The apical clearance method, there is no bearing or touch at the apical area, and the lens bearing is usually directed towards the mid-periphery. The apical bearing area gives a very good quality of vision because it directly touches the cone, but it has a very heavy bearing on the cornea, and long term it may have the development of the proud nebula. So this is usually not recommended. And the 3-point touch has a divided support and is the most commonly used, where the lens bearing is shared between the apex and the mid-peripheral cornea. This is the patient has good vision, better comfort. So here you can see the touch in the center as well as peripheral distribution of the bearing of the lens. And then after fitting the center, we move on to the peripheral edge fitting. So in the peripheral edge, the lens is fit according to the area of the clearance, and edge lift is seen. We should not have such excessive edge lift or very minimum. An optimal edge lift of around 0.5 to 0.7 is usually indicated. After fitting the lens, we then do the over refraction for the patient. Then the final power is calculated after performing the spherical over refraction of the trial lens. So after doing an RGP fitting, when the patient has a over refraction with the spherical and cylindrical power, then RGP may not be the good choice, because in RGP we cannot modify the toric correction to give the astigmatism correction. Only spherical modifications can be done. So in a streep trial fit, usually the plus lens tier is present, and so you should go for a flattening of the base curve by around 0.5 diopters. And when it's a flat trial fit, then we need to remember that the minus tier lens is present, and we need to steepen the lens with a plus over refraction, making it so this is easier to remember is the SAM versus FAP, the steeper add minus and the flatter add plus. So when the trial fit needs a cylinder after doing the over refraction, sometimes when it is very minor and patient almost improves to 6.9 or a 6.6 pass, then if they are ready to wear secondary glasses, then I prescribe a glass number 2 for the patient, where they can still use the glasses when necessary for a finer focused vision. So this is even RGP lens insertion and removal is much easier for the patient, like even small kids can easily be able to do it. So this is little about the method of insertion. The cleaning of the lenses is very much need to be insisted and explained to the patient, that only then they will be able to use the lens for a longer time, because these patients are going to be dependent on these lenses for more part of their life. And making them look at the center, it is directly fit into the eyes. The RGP removal, when taught to the patient, it is done as a one finger method or as the two finger method. The one finger method, we make use of the upper lid. So the upper lid is slightly pulled laterally, and when the patient blinks, it moves the lens, and lens immediately falls off in their hands. Same way, after removing the lens, we need to emphasize to clean the lens and change the contact lens solution in the lens case to replace it. And in the follow-up visit, all these parameters are assessed: the history to grade the comfort of the patient, their tolerance level, the duration of their wear, and then we do a slit lamp examination to assess the lens fit movement and the fluorescent pattern. If we are not able to fit the patient with the RGP lens, yes, we next move forward to the rose scale lenses. These are unique keratoconvex lens designs with a very small optical zone, where it avoids pooling under the lens and gives a uniform fluorescent effect. And Rosque now has a different variety of Rosque too. These are the whole package of Rosque contact lenses available, which can be used for a wide variety of fitting, which is much easier to use than the sclerals, where when I move into the sclerals, you'll understand the maintenance and the care is much more little complicated than maintaining this basic kind of RGP or the Rosque contact lenses. So the fitting, the selection is based on the average K values, where if it is between 5.1 to 6, the first lens is usually applied as the same average K value. If the fitting, the K reading is a little flatter, then we go for a 0.2 mm steeper lens. And then if the fitting is much steeper than 5 mm, then we go for a flatter 0.3 mm flatter than the average K value. After selecting the initial lens, we start the fitting, which is almost same as the RGP lens. When the lens is caught too high, then we need to steepen the base curve or little reduce the overall diameter. The rules for the optical zone diameter is, a good rule of thumb is to flatten the base curve radius by 0.05 mm for every 0.4 mm increase in the optical zone diameter. And for the base curve radius adjustment, also the SAM-FAP rule is used, and a smaller change in the optical zone diameter will yield us a wider peripheral curves as well. And after achieving the best fit of a Rosque lens is usually a centrally fitting Rosque lens, where nipple cones work better and the patient gets optical acuity and comfort. and always fits the central base curve first. And Rosquet to IC is that used for the irregular corneas, which are much having a larger diameter and a larger optic zone. And they also have aspheric designs for better aberration control. This is another technology which is a modification available in the Rosquet lenses. When the patient has the lens is overlying the lower lid, then we can use this asymmetrical corneal technology, wherein there are three graded options from grade 1 to 3, between 0.7 and to 1.3, making it more steeper. And this is how it improves the comfort and lens stability of the vision. Here you can see the increased pooling of the fluorescein over the lower lid. But here, after applying the act of around 0.3, then grade 3, we are able to achieve a good fit. Then there is another modification of the toric peripheral curves, wherein the central spherical curve is maintained and only the toricity is given in the periphery of the lens. The fitting pearls would include, there should always be a light central touch with increased acuity, and we should give an attention to the tear flow beneath the lens. So for a steeper lens, the smaller overall diameter and the less movements. And what we need to remember is we should not change too many parameters at once. Always change one parameter at a time, so that you will have an understanding of what is the fitting process. There is when the patient doesn't feel much comfortable, we have the option of piggyback contact lens, where you get a good fit of the RGP lenses, but the patient is complaining of irritation or discomfort. The piggyback is a soft contact lens placed first, and then over which we place a RGP lens. So this is happens sometimes. The indications is when the RGP keeps popping out and there is a 3 o'clock and 9 o'clock staining in the RGP fit. So for achieving a good piggyback lens fitting, we need to have an optical fit of the soft lens first. Then the base curve of the RGP is determined, and then do a topography on top of the patient with the soft lens fit. And then move on to the fitting of the RGP lens, and always ensure adequate movements of the soft lens and the RGP lenses independent of each other. There are also lately custom piggyback lenses, which are lathe cut lenses, which has a groove in the soft contact lens for fitting of the RGP lenses. But it does have few disadvantages, where the RGP can be lost. Patient may be unaware of that, or the development of a giant papillary conjunctivitis and localized hypoxia and neovascularization. And patients mostly find it difficult to handle or maintain two types of lenses, different lenses. The hybrid contact lenses are not much practiced in India. This is a soft peripheral skirt with the central rigid portion, which has optical neutralizing properties. The manufacture of these lenses also has a higher cost, and the complications are more related towards the hypoxia-related complications, where corneal edema happens, and it's mandatory to examine the patient after 5 years after the lens wear. So scleral lenses, yes, scleral lenses previously were categorized based on the diameter of the lenses. Recently, the new classification after 2015 gives us that lens classification is based on the bearing of the lenses. The corneal lenses rests on the cornea only. The corneoscleral rests on the cornea with just a scleral touch. The scleral lenses can be either mini scleral or the large scleral lenses. The scleral bearing in the mini scleral lenses has the lens with the 6 millimeter larger than the horizontal diameter. If it is much more larger than 6 then it is a large scleral lens. The corneoscleral lenses are useful only for a moderate keratoconus with low sagging cones. The mini scleral lenses has different parts of the lenses, with the central zone, the peripheral zone, the landing zone, and the scleral zone. So coming to the scleral design of the lenses, the true scleral lenses are more than 18 millimeters with 6 bearing on the sclera. It vaults and rests on the sclera. It has two modifications. It can be either a fenestrated or a non-fenestrated variety. The fenestrated variety was developed to give more oxygenation to the tissue, but it was not much successful because of the air bubble formation under the lens, which was again compromising the vision. The non-fenestrated scleral lens is the pros or the prosthetic replacement of the ocular surface ecosystem by the Boston site scleral lenses. So in this, they have different technologies to improvise the lens, wherein it has the junctionless vault control of the spline technology, as well as the smart channel technology, wherein they can modify the lenses in the edges so that it can even avoid any other anatomical change required for in the sclera or the conjunctiva. For fitting the scleral lenses, we should be first choosing the diameter of the lens and then establish the central and then the limbal clearance, the landing zone alignments, and then adequate edge lifts are looked into after proper sizing of the lens. So the corneal diameter plays an important role, wherein a smaller cornea, we need to use a 15.9 mm lens. For a larger corneas, we use more than 16.4 mm lens. And the sagittal depth is having the is within the bowl of the scleral lens, and vaulting is the key. So a good vault will give you a good fit. And for higher corneal elevations, we have to use a higher sag lens, and for lower corneal elevations, we need to use a lower sag lens. So how to select the initial scleral lens? It can be done with either of these methods: the radius of the cornea method, the sagittal depth of the cornea, or the middle of the first set method. So either by choosing the steepest K reading, and the scleral lenses can be fit based on the OCT of the patient, which gives sag with the same central corneal radius. The sag can be different, and so this patient needs to be started with a higher sag lens. Or the available scleral lens with you, you can go and select the middle of the set. And then when you fit in that, like what you observe, you can see either the patient is going to have a very little clearance, or too much clearance, or an appropriate clearance. So based on that, you can do the modifications of the sag adjustments. By having the apical touch, you can increase the sag 0.1 mm for every 1 mm of touch to eliminate it. In this example, if you can see a 2 mm touch in the central cornea, which is a 4.6 sag. So to eliminate that, when we fit a 4.8 sag, then the patient doesn't have a touch in the center. So this is the evaluation in the slit lamp, where you evaluate the front surface of the lens, and then the back surface of the lens, and this is the fluid reservoir layer, and then the cornea is seen whether it is having the touch. So this is the approximate measure of the sizing of the fluid reservoir you're seeing in the slit lamp. The ideal vault should have somewhere between 150 to 300 microns after the final fit in the settled state. If the patient has a 300 microns is in the settled state, then the clearance is much higher. But for a perfect fit, it needs to be a little lesser. After fitting the central clearance, finalizing the central clearance, then you move on to check the limbal clearance. Limbal clearance should be somewhere between 50 to 80 microns, and then when the patient has an unacceptable limbal blearing, or when it extends beyond the limbus, may it happen because of a large diameter lens. After the limbal clearance is checked, then we evaluate the edges of the lens. This is the ideal fit for the edge. We don't want either an impingement or an excessive lift. So for all this, yes, it's important for us to know the scleral shape of the sclera also. Nowadays, there are scleral profilometries done, where the average angle from the 10 to 15 mm of chord length of the sclera and the 15 to 20 mm of chord length can be identified. And what they have observed is that the 15 to 20 mm has a wide increased variability significantly from 36.6 to 43.3, which is steeper inferotemporal sclera. So the fitting also should have all these into account to give a good fit for the patient. So this is a good lens alignment, where the clinical mark you can see is the continuity of the vessels, which don't get blocked or become avascular in between. And then with the shadow, you can identify the edge lift. And with mild fluorescent tear pooling, it means it's much flatter. And this shows the impingement, where there is bogginess of the nearby conjunctiva with congestion. Then compression is also not required, because even during the fit, when you have compression, when the patient is going to wear the lens for much more longer hours, it will have a compromise in the sclera. And after getting the ideal scleral lens fit with the central lens, and movement should not be there for a scleral lens, with a minimal vault, a no cornea touch, and edge alignment. These are the parameters for a well-fit scleral lens with around 150 microns once the lens is in a settled state. There are modifications which can be done. The notching, a scleral lens with a notch can be given to fit the pincula the patient has, and truncation when the patient lens is going to override the lower lid. There is also availability of the HydraPEC coating for the scleral lenses, which improves the wettability for a patient not to have the lens fogging. And we can also evaluate the patient with the OCT. This is after the 4-hour application of the lens, so that in a settled state, we should not observe any particulate matter in the tear reservoir. So, like the topography from the morning, what we have heard regarding the different machines available, there is also scleral profilometry, which is coming up for the lens fitting. Because it is understood that not one size fits all. The traditional process of scleral lens fitting is like what we have, we give to the patient. But this is a more customized variety, wherein a best fit sphere of the sclera is taken, and then patient's scleral profile is determined up to around 20 mm of the sclera. And based on that, we can give much more customized fit to the patients. So after assessing and deciding on what lens you're going to fit, the patient needs to be taught on how to use the scleral lenses, which is a very important part of this lens dispensing. So patients should have these, basically all these to be ready for the fitting of the scleral lenses: the insertion plungers, a mirror, and clean towel, and the solutions. The patient needs to look below, parallel to the ground floor, and patient can help us by pulling the lower lid, where the examiner can pull the upper lid, and then this movement should be pretty fast one, wherein you, after having it, the lens inserted with the plunger into the patient's eyes, and then you observe for bubbles. If the bubble is there, then they definitely need to remove the lens and reinsert. While teaching the patient, all patient doesn't need a plunger. So after all patients doesn't need a plunger, even they can insert it with their own hand. Should be filled up to the brim, or a little more than the brim. And this is the other variety, but this the patient usually feels much easier to handle, because they have an aid with the plunger. So always the cleaning of the lens is insisted. So after cleaning the lens, then with the plunger, putting a little drop of saline in the plunger, the lens is fitted, and then the normal saline or the pro saline is filled with. And when we are examining, we put the fluorescein into this fluid, and then check for the clearance while doing the trial fit for the patients. So ask the patient to look down. Patient can help us by lowering the lower lid for us, and then we insert the lens. Same way for removal, we can put a little drop of saline, and there are removal plungers which are different from the insertion plungers. And the patient is asked to look a little down, and the lens can be removed directly. And apart from the plunger removal, yes, the patient can remove the lens with a little bit pushed outside, and it is easier to remove. But scleral lens removal is little difficult, and because it has the vacuum, much difficult than the regular RGP lens removal. And otherwise, if you can insist to have a removal plunger. So after fitting the lens and teaching, after removal of the lens, you should stain the conjunctiva with fluorescein to find out any rebound hyperemia, any impression ring is there, punctate staining is there. And based on the compression, you can also do a modification of the edges. A toric haptic can be given, or even quadrant specific changes can be given. Any debris remnant should be looked for. Even lissamine green stain can be used to identify the damage and the dead cells, conjunctival cells, and the lens alignment with the edge lift and the fluid influx into the post-lens reservoir. Here you can see the staining of the lissamine green in the conjunctival area. So accordingly, you can modify the edges. So after doing everything, the final dispensing of the lens after the over refraction, you always insist to assess the lens after a 4 hours wear of the lens, because in half an hour or 1 hour the patient will be comfortable, but when they are going to use it continuously on a later date, we should always ensure that the patient should not have any future trouble. So after 4 hours, and in case the patient wants to wear the lens more than 4 hours, you can ask them to break and refill the saline and then continue use for the next 4 hours. And the binocular assessment of the best corrected visual acuity with both eyes open needs to be appreciated by the patient. So with the scleral lens, yes, you can always bring a patient from a nearly blind to a very clearly seeing eye. The articles from one from clinical ophthalmology, the scleral lens for keratoconus, the technology update also gives a maximum scleral lens for advanced keratoconus with a near ad design also. And in another article in review of cornea and contact lenses, Mahadevan et al. Showed that the front surface eccentricity value, which is like a pros lens with a 0.6 to 0.8, can improve patient's vision in even very advanced keratoconus. And there are a different variety of scleral lenses and different fitting grades where we can even change the mid-peripheral value, the limbal value can be changed independently in these scleral lenses in even 25 micron to 50 micron steps and can be fitted more accurately in the patient. The other variety of scleral lenses wherein they have the limbal curve indicators, and accordingly they precisely determine the width of the optic zone and then dispense the lenses. We need to have these at the back of the mind, the complication of the contact lenses, where it should not cause any corneal structural changes, dry eyes, and the possibility of microbial keratitis over long time wear, and poor method of use of the salines. And this article in the International Journal of Research, the contact lens fitting in keratoconus, a prospective study on visual and functional outcomes, they have stated that even in mild to moderate cones, the use of RGP lenses itself brought a much bigger impact on the patients and need not go for higher complicated variety of the scleral lenses. The other studies, cross-sectional studies, comparative, the efficacy of comfort of the GP and the soft lenses, the scleral hybrid lenses are all available. And the long-term studies are the collaborative longitudinal evaluation of keratoconus study and the Dundee University Scottish keratoconus study, where both of them tell that the patients who wore these lenses were more comfortable, and it definitely was the mainstay of treatment, which improved the patient's vision. So this for any variety of lenses we are going to dispense, the lens care and maintenance should be insisted to the patient again and again. And the improper interchange of use of these solutions also need to be once explained to the patient. So there are patients who come back using cleaning with the saline and using the disinfectant to fill in the scleral lenses. So all these small things need to be explained. And when I dispense a patient, I also send across a video guidance for these patients so that it's a teaching module for them. And after selecting the lens which we are now going to fit, this is the overall thing for any patient who comes with the keratoconus. Depending on the patient affordability and also the type of cone, whether it is early or advanced, then we need to go for what kind of lens we are going to select and work accordingly. I just have a few cases. This was Mr. Kannan, 15-year-old male with the keratoconus and right eye post C3R. The uncorrected visual acuity was 618 in the right eye and left eye was 2/60. After doing a specialty topography, the right eye was selected for a ROSE K2 trial. After dynamic and static fitting, the final parameter dispensed was ROSE K2 keratoconus lens.
Blink, blink.
So you can see a nice well-centered lens with a good peripheral edge. And the left eye was a very advanced cone. Patient was advised for a toric scleral contact lens trial. So in this, the patient was assessed after having a good diameter. The little decentration was noted, and the clearance was very less, and because of the decentration. So after doing an over refraction, the patient was got a trial lens. And when we applied the trial lens and did the OCT, we could see only a 187 microns before the settlement. So which is very less for clearance for the patient. So then we had to do a modification for this lens. The alteration we did was the superior limbal wall to increase it to more than 100 more microns, and a toric peripheral grade 1 was given. And after that, the patient improve with the good clearance, and our clearance increased to 333 in unsettled state. So in a settled state where a patient would be much, it worked better for him. The other patient is a known case of keratoconus with CTR in both eyes. The patient was already using a scleral lens in the right eye and the RGP lens in the left eye. This patient had an anterior corneal scar, and he was not fitting with an RGP lens. The left eye was fit with the RGP lens, and these are the final parameters for the left eye. And the right eye, the patient was taken for a scleral lens fit, and he was advised. So this is the missing link to complete the circle. And finally, you would have a happy patient and reviews from your referrals doctors as well. So make a difference to your patients by not only making them see the leaves, but also making them see the dewdrops in the leaves. Thank you.